So this is the lecture looking at the atypical antipsychotics, or the second generation antipsychotics. And what distinguishes these drugs from the first generation is that they have a much more profound serotonin blocking ability relative to dopamine. And so these are kind of becoming the frontline therapy for schizophrenia, both because they're relatively good at treating both positive and negative symptoms, but moreover because there's a much lower incidence of the side effect EPSE, which was discussed in the previous video, with the exception of that being risperidone. And so from a mechanistic standpoint, again, we're looking at a preferential blockade of serotonin receptors, of course, relative to dopamine. And we actually talked about these drugs in various capacities in the previous cases. And so you can see them used for other diseases. Currently, they're second-line therapy for OCD, SSRIs, of course, being the first. And so the side effect profile includes effects that are less dopamine and more serotonin-like. And so, weight gain, diabetes, hyperlipidemia, metabolic alterations are really due to persistent kind of serotonin receptor blockade. Some interesting notes on individual atypicals. Clozapine, risperidone, and ziprasidone have the ability to also block alpha. So you can see the production of orthostatic hypotension as well as the accompanying tachycardia with these drugs. Clozapine and olanzapine also offer some muscarinic receptor blockade and can produce hyperlipidemia. Excuse me. All these drugs have some degree of H1 receptor antagonism, which can promote sedation. Ziprasidone specifically has the ability to alter the EKG and produce QT prolongation. Risperidone, which is beneficial in OCD and Tourette syndrome, has the highest degree of producing the side effect EPSEs. And then again, you can see metabolic changes kind of across the board. So the prototype here is clozapine, and this is really the best drug for those problematic negative symptoms. As a rule, this drug really has not produced EPSEs, and it, to date, has not really been associated with the production of tardive dyskinesia. So this is a great drug. It has anti-serotonin activity, but it also shows some type of frontal cortex activity. We're not really sure on that mechanism, but it does have great efficacy. But we typically don't use it because of a few relatively minor but pesky side effects, 4 of which are listed here. 1% of patients can produce or can develop agranulocytosis, and so for that reason you must monitor neutrophils of these patients that are going to go on this drug. Cardiomyopathies can occur as well as with clozapine. This drug can also lower the seizure threshold, and paradoxically can produce wet pillow phenomena. Even though it has anti-muscarinic effects, it doesn't seem to have the muscarinic effect within the jaw and the salivary glands. But it does have some unique pharmacology. In terms of its dopamine receptor blocking ability, it seems to offer affinity for the D1 receptor more than the D2 receptor, which could explain some of its beneficial uses. Likewise, there's a higher affinity for the serotonin 2A subtype receptor than there are for any of the dopamine receptors. And it's got relatively strong affinity for the D4 receptor, which is more kind of peripheral. This drug's highly anticholinergic, and there also is some alpha-1 and alpha-2 blocking. And so clozapine is really unique. And I said a lot of the drugs that are the most efficacious tend to be the most diverse in terms of their receptor affinities, and surely clozapine kind of suffices that rule of thumb. And so because of clozapine and how beneficial it is, it kind of gave way to a bunch of drugs, 3 of which are listed here, and many of these we've already talked about. And so we call it the clozapine revolution. So these are kind of second and third generation clozapine molecules that are almost as efficacious but lack some of the side effects. And so olanzapine is pretty much like clozapine, it's not as strong, but it doesn't really produce agranulocytosis, and so patients with underlying neutrophil pathologies and so forth can easily be given olanzapine. Likewise, risperidone is as efficacious as clozapine, but it is capable of producing a dose-dependent EPSE. Quetiapine, which we've talked about in previous cases, has mixed dopamine and serotonin antagonist abilities. And so other indications for these drugs, and these are the cases where you've seen them: bipolar disorder, depression, severe depression specifically, and anxiety, OCD, specifically with Tourette's and tics, and then you can see off-label sedatives, insomnia, and agitation. And so these are the kind of the major take-home points for the second-generation atypical antipsychotics, and that concludes this lecture.